So patient details. This patient, Miss XYZ, 22-year female, presented from Sundargarh, Odisha, tailor by occupation, right-handed person, and date of admission was 10th April, and informant patient being herself. Presenting complaints, neck pain since 5 months, weakness of bilateral upper limb 5 months, weakness of bilateral lower limb 4.5 months, and wasting of hand muscles 1 month. So these are the presenting complaints. History of present illness. Patient was apparently alright 5 months back. To start with, she developed pain in her neck, which was insidious in onset and diffuse in nature without any radiation and no relieving or aggravating factors. After
Doctor,
4
if
to
there
5
is
days,
radiation, what will you think?
sir, if there will be radiating, then we'll be think of radiculopathy, sir.
Okay, good. Carry on, doctor.
If there will be any compression of the root or there will be aggravating factors like the pain will be sharp shooting and lancinating in nature with the pain increasing on coughing, sneezing or bending forward. But
Okay.
there was no such history of radiation or any aggravating or relieving factors.
Okay.
So then after 4 to 5 days, she
What
felt
is
weakness.
Lehermet's sign?
Sir,
What is Lehermet's sign? Or
Lormet
Barnett
sense
sign?
around bending the neck forward, there will be a current-like sensation running from neck to downward to the spine, seen in the posterior column involvement, sir.
Conditions like
Also in demyelinating disorder like MS, and in it is the significance of posterior column involvement.
in
The
cervical
current-like
spondylosis.
sensation running from neck to downward the spine.
Okay, good.
Then, sir, after 4 to 5 days of that neck pain, she felt weakness in her neck, which was also insidious in onset and progressive in nature. Initially, her head was falling forward while sitting for doing her tailoring activity and could only lift her head with difficulty. Initially, she has difficulty in extending her head. Then, after 2 to 3 days, she experienced pain in the left shoulder joint and elbow joint, which was jaw-lacking in nature without any swelling or radiation and neither associated with stiffness nor progressive. And she felt weakness in her left upper limb, which was insidious in onset and gradually progressive. Initially, she experienced difficulty in raising her arms above head. H, she had difficulty in reaching her objects placed the upper cell, and she also had difficulty in wearing the dresses and applying soap on her upper part of the body.
So what does this indicate?
So,
Difficulty in
she has,
raising her arms above head,
yes, sir,
difficulty in reaching
this
for objects
signifies
in
a
upper shelf.
proximal involvement of the upper limb, sir.
Proximal
She
muscle
has weak
involvement in the
proximal
upper
muscle
limb.
involvement, yes, sir.
So in which condition, which disorders, neuro axis, the proximal muscles are more involved?
Proximals are generally involved in lower motor type, sir. In lower motor type,
Proximal muscles are involved in which condition?
sir,
Proximal, see, these all
yes, sir.
are directed to the proximal muscle involvement, which you
Proximal
have
muscle, yes,
rightly
sir.
said. So what
Yes,
disorder produces predominantly proximal muscle involvement?
sir. Myopathy, sir.
Very good. Myopathy produces predominantly proximal muscle
Proximal
involvement,
weakness, sir.
whereas neuropathy produces a predominant
Distal weakness,
distal muscle involvement. Of
distal
course, there
muscle.
are few exceptions. You
Yes,
have
sir.
distal myopathies also, but there are very
Yes, sir.
few conditions. But
Yes, sir.
by and large, myopathy presence affects
Proximal, sir.
proximal muscles more than the distal muscles. What
Yes,
are
sir.
all the other conditions which make you think that it is myopathy? One proximal
Sir,
involvement.
now one is the pattern of distribution that is proximal.
Very good.
Another is this is symmetrical actually. Initially, he had upper limb symmetrical, then lower limb. As we go on the history, we will see the symmetry of this presentation.
So
And
one is the
sir,
proximal muscle involvement.
involvement,
Second is symmetrical.
symmetrical.
Third, there will not be any sensory disturbances.
Sensory,
Of
yes,
course,
sir.
you are going to come in
Yes, sir.
history, but I
Yes, sir.
just want to interrupt it so that I don't forget. So there will
Sure,
not
sir.
be any sensory symptoms.
Sensory involvement.
And the
And
reflexes are
sir,
usually present
one more thing, there will be
unless the muscles are
disproportionate.
severely affected.
Sir.
Why in neuropathy the distal muscles are affected?
Sir,
And in
neuropathy, there will
situations
be
the distal
length
parts
depend.
are affected.
So neuropathy, there will be there may be axonal loss, and that is length dependent, maybe for that reason, sir.
Very good. Neuropathy, we have two types, axonal type and demyelinative type.
Demyelinating type,
Axonal is a length-dependent
length
neuropathy.
dependent, sir.
So
Sir,
the
sir.
lengthier the nerves, they are the first to get affected. So
affected.
the nerves of the lower limbs are the lengthiest. So it starts affecting the foot and then slowly starts ascending. But as and when it comes to knee, it
Sir,
approximates the length of the hands. So once
sir,
it
sir,
starts ascending from the foot to the knees, the upper
sir,
limbs
sir,
also should start getting affected.
affected.
So from the foot, when it comes to the knee and slowly starts ascending, the upper limbs also will start getting affected. So
Affected,
this
yes, sir.
indicates length-dependent neuropathy, axonal neuropathy, be it motor, be it sensory. So glove and
Sensory.
stocking type of sensory loss. Motor, we say distal more than proximal. And we say sensory, we say graded sensory loss.
Graded
Because the
sensory,
distal
yes.
parts are most affected and then slowly it starts ascending. Whereas demyelinated neuropathy, proximal and distal are almost equally
Equally.
affected. It's not length dependent neuropathy. It is length independent neuropathy. The classic example is Guillain-Barré syndrome. Okay. Yeah.
Sir,
Continue.
sir, after 7 days, she also experienced the similar weakness in her right upper limb also. As she had difficulty in taking bath and pouring water above her head, and difficulty in reaching her hand above to comb her hairs. A similar proximal weakness in right upper limb also in a span of 7 days.
Okay.
Then, sir, after 6 to 7 days, patient also had similar pain in her hip joint, like the pain, arthralgial type pain in left shoulder she felt, similar pain in the hip joint, and also simultaneously she felt weakness in the both the lower limbs. Initially, she had difficulty in getting up from the squatting position, like after doing her daily activities, like after coming from bathroom, she was using her hands on the floor first, then above the thighs, but then she used to get up with the support of the hand above the thighs. But he has no joint pain either in knee or ankle, and weakness was insidious in onset and was gradually progressive also.
So what is this sign known as? You
Sir,
said she's
first there
using
will
her
be
hand.
tripod sign, Gover sign, hip up sign, sir.
Yeah, Gover's sign. So they
Gover
climb
sign.
on themselves because the proximal muscles are affected.
Affected.
Fine. If the abductor is affected, gluteus medius gets affected, what will be the kind of posture or gait?
If abductors are
Gluteus
affected,
medius affected. Yeah,
sir, hip up
abductor.
sign,
Yeah.
hip up sign, sir, hip up sign. The hip
Uh,
will be not supporting
Gluteus medius is responsible for abduction of the hip.
abduction of
And
the hip, yes, sir.
therefore, if the gluteus medius is functioning well, so once it contracts, the pelvis on that side will come down. The other side
Trendelenburg sign will be there.
yeah, will raise. But if the gluteus medius gets affected, when they walk, the other side pelvis will not raise. It will fall
Not
down.
one.
It is known
Fall
as
down.
waddling gait.
Waddling gait. Yes, sir. If bilateral involvement, then there will be waddling gait. This person had waddling gait, sir. If
Okay,
only
fantastic.
unilateral, then there will be Trendelenburg gait, sir.
Yeah, and one more history you can ask regarding lower limbs is that whether the person is able to walk well on heels or whether the patient is able to walk well
Oh,
on toes. What
oh.
does that signify, Dr. Agasti?
Tripping that signifies lower motor neuron palsy or foot drop.
Walking on heels means
Heel.
patient is able to dorsiflex well.
Dorsiflex well,
If
yes, sir.
he able to walk well on toes, that means
Oh,
he's able to plantar flex well.
plantar flex.
So if the plantar flexors are strong, he can walk on toes. If
Close. Yes,
the
sir.
dorsiflexors are strong, then he can walk on heels.
Yes, sir.
Sometimes
Yes.
this is L5, this is S1. Plantar flexion
L5.
is L1, S1, and
Sir.
dorsiflexion is L5. So
L5.
if dorsiflexors or L5 gets affected, they cannot walk on heels. If
Mhm.
plantar flexors or S1 is affected, they can't walk on toes. Because,
Sir.
for example, some diseases like Miyoshi disease affects gastrocnemius,
Posterior, yes, sir. Nanoka affects anterior compartment and Miosi affects posterior compartment.
posterior compartment. So gastrocnemius gets affected. When
Yes.
gastrocnemius gets affected, they have problems in walking. Okay,
Working, yes, sir.
right.
Yes, sir.
And suppose the abdominal muscles and hip muscles are affected, they'll have lumbar lordosis and they'll
Sir.
have toe walking also. Okay,
Sir,
right.
sir.
Lumbar
So,
lordosis indicates weakness of the abdominal muscles. So it
up-
becomes forward. Okay. So that by looking at the way they walk, the way they stand, very interesting. You can pick up a lot of clinical clues. In fact, clinical neurology is very, very interesting. I always compare listening to the history and getting clues is like a detective cracking a mystery. Okay. So if you listen attentively and get clues, you can solve the problem. Okay,
sir,
right.
sir, sir. So after she had proximal weakness in bilateral lower limb, she also had difficulty in climbing stairs, age experienced by unable to lift thigh and put on the next step, and had difficulty in getting up from chairs and was taking the help of family members for getting up. She had difficulty in climbing upstairs and also had difficulty in getting up from chairs. So he had sir difficulty in hip flexion and also hip extension, sir.
Okay.
So after a few days, she also had difficulty in paddling the swing machine in her left foot. She was tailored by occupation, was doing paddling activity for swing. So she had now involvement of the distal muscles for which she had difficulty in paddling, like that. She is unable to do that plantar flexion and dorsiflexion properly. For that, she started using her right foot for paddling, and after few days, she could not do the same even with the right foot.
So not only proximal muscles, now her distal muscles are also getting affected.
Distal also, after few days, after 10 to 15 days, she developed distal weakness in the bilateral lower limb also.
Okay.
Then after few days, she had difficulty in getting up from the lying position and she needed help of another family member to lift her up.
Suppose a person has got difficulty in getting up from, suppose,
Lying position.
what is Beaver's side?
Reverse sides are, if there will be weakness in above T10 level, while getting up, the umbilicus will be pulled upward.
Very good. A lesion at T10 or below, the lower abdominal muscles
Lower,
cannot
sorry,
function well.
cannot contract.
When
Yes,
they
sir.
try to get up from supine to sitting position, the upper
The
abdominal
umbilical
muscles will pull the
will be
umbilicus
contracted.
upwards. This is known as Beaver's
Upwards.
side. So
Reverse
another
side.
important clue to find out whether abdominal muscles are involved or not.
Yes, sir.
Right.
Yes. Sir. Then, sir, gradually she had uh, difficulty in bending her head forward while trying to get up from the sleeping position, and also had difficulty in lifting her head up above the pillow. That means she had difficulty in flexors of the neck muscles, sir, while getting up from the sleeping position. So
Yeah.
then, after 1 month back, she noticed gradual wasting of her hand muscles, and she complained of gradual difficulty in holding objects in her hand, and she was not able to do her sewing activity and unable to hold the objects tightly.
Okay, if the person has got difficulty in holding objects in her hand, right? But
Yes,
then you ask her to hold it, she finds it difficult. But with great difficulty, she holds it. And if you ask her to release, if she is not able to release the object which is held, what will you think and how does it help in your case presentation?
there will be delayed relaxation. That means myotonia, sir. We can think of myotonia, that is delayed
Very
relaxation.
good, very good. So this is an indirect way of assessing whether myotonia is present or not.
Myotonia.
Because
Yes,
when you start presenting a case on muscle disease, history of myotonia is very, very important. So
yes,
you
sir.
can have myotonic dystrophy, proximal
Yes, sir.
myotonic dystrophy type 1 or type 2. Type 1 affects distal muscles, type 2 affects the proximal muscles. And not only that, channelopathies also can present with myotonia. So you can get a very good clue whether it is a channelopathy causing myotonia or myotonic dystrophy type 1 or type 2. Okay, right.
Yes. So then, sir, there was also history of intermittent low-grade fever with pain in the weakening muscles. That is myalgia. And the patient also complained of dysphagia to solids only in the
So a
late phase.
person has got fever means again here now you slowly start getting clues with pain. That
Pain.
means patient may be having some inflammatory pathology going
Exactly, sir.
or
Exactly.
infection going on because patient is
Infection
having
or inflammation. Sir, sir.
and pain. Okay, good.
Okay, yes, sir. And the patient also complained of dysphagia to solids only in the late phase of deglutition, age experienced by feeling of something sticking in the chest during deglutition, which is improved now.
So
She
now
also,
what does this history suggest you?
sir, involvement of esophageal muscles, sir. During deglutition, we have oral phase, pharyngeal phase, and esophageal phase.
Okay, fine. So
So,
when you present a neurological case, especially regarding a muscle disorder, should always comment about ocular muscle involvement and muscles of
uh, muscles of the pharynx,
yeah,
neck,
following.
neck.
Okay, right.
So,
Because we have a lot of entities like oculopharyngeal muscular
yes, sir,
dystrophies.
yes.
Okay, right.
So, then, sir, she can differentiate between hot and cold
So I
and
think
can
now
feel
with this you have finished about motor. Now you are going to
motor, yes, sir. Sensory,
yeah.
yes, sir. She can differentiate between hot and cold and feel the touch of the clothes over her body. Sensory was intact. Sir. So then coming to negative history, sir, there was no fasciculation or any abnormal
What
movement.
what so what do you want to convey, or what do you want to, what information on next slide? What information do you want to get
Yes, sir.
by saying
Sir,
there's no fasciculation? Because every point you make, you should justify yourself
justify.
why
Yes,
you have asked.
yes, sir. In fasciculation, we rule out, sir, the anterior horn cell involvement or motor neuron disease.
So fasciculations are caused by anterior horn cell,
Anterior horn cell. Yes, sir.
like poliomyelitis or ALS,
Poliomyelitis,
amyotrophic
ALS.
lateral
Yes, sir.
sclerosis. What
Amyotrophic.
is the mechanism of fasciculation? Why they have spontaneous muscle twitches without any voluntary effort?
Sir, due to continuous discharge from the anterior horn cell, sir.
Yeah, this indicates that the anterior horn cells
Anterior horn
are
cell
dysfunctional.
dysfunctional.
This is because of a law known as Cannon's law of denervation supersensitivity. So when the
Cannon's law. Okay.
anterior horn cell gets affected, it is denervated. So it becomes super sensitive to its neurotransmitter, that is
Yes, sir.
acetylcholine. So once it becomes super sensitive, even without your effort, it contracts involuntarily and starts throwing muscle twitches because of denervated supersensitivity. It indicates that anterior horn cell is dysfunctional. It is denervated.
Dysfunctional. Yes, sir.
So it has
Yes, sir.
become supersensitive to its receptor, to its neurotransmitter, acetylcholine, and there are spontaneous muscle twitches. So you see, if you see fasciculations, you always think of anterior horn cell disease.
Anterior horn cell.
Here
Yes, sir.
there is no fasciculation,
No
so
fasciculation.
perhaps this is not in the anterior horn cell disease.
Anterior horn cell.
Fasciculations, EMG we do and pick up fibrillations. Okay.
Yes, sir. Then, sir, there was no fatigability, diurnal variation,
Wait,
and
wait, wait,
history
wait.
of
Why you said there's no fatigability?
sir, to actually all these three negative history I have included for involvement of neuromuscular junction, sir. There will be if there will be
No, no.
involvement of
Fasciculation is for mainly anterior horn cell disease.
anterior horn cell, sir.
Okay. Fatigability and diurnal variation of weakness.
Variation
What you
and
want to
drooping of
convey?
eyelid also. Drooping of eyelid and diplopia means
No, wait, wait.
extraocular muscle
No, no, no,
involvement.
no, no. We'll go step by step. You
Yes,
said
sir.
fatigability. Why did you say fatigability? No fatigability.
To rule out
Why did you ask that history?
to rule out any neuromuscular junction involvement, sir. Like myasthenia gravis, there will be initially there will be no fatigue or some activities. You will not feel fatigue, but after doing that activity, see may slowness in that activity or will feel fatigue.
Okay, good. So
Neuromuscular junction.
NMJ disorders, there'll be fatigability. Why did you say no diurnal variation of weakness?
Same, sir. To for neuromuscular junctions itself, sir.
Fatigability, another history also you can ask. What history did you ask for fatigability?
I asked if in the daytime say drooping of eyelid, or I asked her actually if she was able to do the wax properly in the initial steps, and after few times like she was doing sewing activity, I asked her if there was weakness, increased weakness after doing some time of sewing, if she was feeling weakness or fatigueness in the movements.
Okay. One good history you can ask is about chewing. Suppose if she's a non-vegetarian, she's eating a hard chicken. Initially, she's able to chew well. But after a few minutes, she cannot even chew well. She'll be surprised herself. What is this? I was able to chew well and enjoy the taste. Now I'm not even able to chew. So as the time progresses with the passage of time, they cannot perform the activity. So fatigability. So that is one history you can ask. So no diurnal variation of weakness. Okay.
And no history of drooping of eyelid also, sir.
Yeah. What
And
do you
no
want to
history,
suggest by no history
no
of
history of
drooping of the eyelid?
diplopia. Since extraocular muscle involvement, sir.
Drooping of the eyelids, what does it convey to you? No history of drooping of eyelids.
So there will be drooping of eyelids are seen in myasthenia gravis also, sir. Neuromuscular junction involvement.
It can be seen in third nerve palsy also.
Yes, yes, sir.
Ptosis.
This one, to rule out involvement of third nerve as well as neuromuscular junction, sir.
Okay. See, the elevation of the eyelid is done by which muscle?
So LPS, sir, levator palpebris superior.
Closure of the eyelid.
Or generally with gravity or with force orbicularis occuli, sir.
Okay. Levator palpebris superioris is supplied by the which
Seventh
nerve?
nerve, sir.
Levator
Third,
palpebral
third,
superior,
third,
third nerve.
nose. Third node.
Orbicularis
Orbicularis
oculi
oculi is seventh node.
is seventh nerve. So
Seventh
if a
node.
person has got difficulty in opening the eyelid and closing the eyelid, what will be your inference? Is it a
Difficulty
muscle
in
disease or
opening.
a cranial nerve disease? Person
Difficulty in
complains of
opening.
difficulty in both opening the eyelids and closing the eyelids.
Difficulty in opening and closing. Neuropathy, sir. Cranial nerve involvement.
Cranial neuropathy is unlikely. Why?
Unlike
Because the opening of the eyelids is done by third nerve. It is
third nerve.
present in the midbrain. Whereas orbicularis oculi is responsible for closure of the eyelid. The seventh nerve is present in pons. So for a lesion to affect midbrain and pons is a very lengthy lesion.
Unlikely. Yes, sir. Unlikely.
Unlikely. But opening of the eyelid is done by levator muscle, palpebral superior as a muscle. Closure of the eyelid is done by orbicularis oculi, which is also muscle. So a
Muscle.
myopathy will affect both the muscles.
Both. Yes, sir.
So
Correct. Good.
opening of the eyelid and closure of the eyelid, if that is the kind of history which is forthcoming, then you think more of a myopathy
Myopathy.
rather than a separate third cranial nerve involvement and a seventh cranial nerve involvement.
Sir,
Okay. Right. Then you said no history of diplopia. What did you ask, diplopia?
I asked
What
if there is vision of two double vision, sir. Like if any object is visible, like two objects,
right. Okay.
either
If a person complains of double vision on looking at far off objects, what is your impression? If a person complains of double vision on looking at a near object, what is your impression?
so for distance object and near objects, there may be accommodation defects, sir.
If a person complains of double vision on looking at far off objects, it is lateral rectus palsy or a sixth nerve palsy. Lateral rectus is responsible for abduction. So if
Abductors,
sixth
yes, sir.
nerve is affected or lateral rectus is affected, which is responsible for abduction, they'll have double vision on looking at far off objects.
Higher object,
Whereas medial rectus is responsible for adduction.
abduction.
So it is supplied by third nerve. So if medial rectus gets affected, they'll have double vision on looking at near objects. So double vision on looking at far off objects is a sixth nerve palsy. Double vision on looking at near objects is a third nerve palsy.
Third
And
nerve pulse.
for a person to have double vision, usually there should be asymmetrical movements. If
Yes,
there
sir.
is a loss of symmetrical movement, it will not produce double vision. You got it? For example, this is a very important history to differentiate supranuclear gaze palsy versus the third, fourth, sixth nerve cranial nerve palsy, infranuclear. If it is third, fourth, or sixth nerve per se get affected, like sixth nerve means double vision on looking at far off objects, third nerve means involvement means double vision looking at near objects. But if it is a gaze palsy, like saccadic pathways involved, like front light fields area number 8 is responsible for pushing the
Yes,
eyes
pulse.
towards opposite side. We
Opposite
call
side.
it
Yes, sir.
PPRF. So if frontal lobe gets involved, eyes cannot move to the opposite side. Eyes will be looking at the same side and
Same side.
immediately will be on the opposite side. So when the frontal lobe is affected, eyes are not able to move, but it will not produce double vision because they are not able to move together. It is
Together.
symmetrically it is affected. So only an asymmetric movement of the eyeballs will cause double vision. A
Double vision.
symmetric movement or absence of symmetric movement, that means they stay together but in a symmetric manner, that will not produce double vision. That's why
Double vision.
one important point to differentiate between supranuclear and intranuclear third nerve, cranial nerve palsy, oculomotor nerve palsy is to find out whether there's double vision or
Symmetric.
not.
Okay,
If
sir.
there is double vision, it is an intranuclear palsy. If there's no double vision, there is a supranuclear palsy. For example, front light fields area number 8, it cannot push the eyes towards the opposite side. Eyes will be looking towards the same side, but it will not produce double vision because it is
Not
symmetrically present. Eyes are symmetrically present looking to one
symmetric.
side.
Yes,
And
sir.
what is another way to differentiate supranuclear third gaze palsy from the infranuclear ocular motor nerves? Supranuclear oculomotor nerve palsy from the infranuclear oculomotor nerve palsy. Oculomotor means I'm talking about third, fourth, sixth. The infranuclear oculomotor nerves are affected per se. So if sixth nerve is affected, whatever mechanism you try to do,
Yes, sir.
whatever stimulation you try to do, it will not move because final pathway is affected. Whereas supranuclear gaze palsy, for example, frontal eye fields area number 8 is affected. Eyes are not able to move, but still you can move it. You can make it to move by vestibular stimulation. If you pour warm water, or if ask him to look to one side, or by pouring warm water, you are stimulating the vestibular apparatus, which is also going and connecting the PPRF. Both the frontal eye fields area number 8 is going and connecting the PPRF. Vestibular apparatus is also going and connecting the PPRF. You put warm water, it will stimulate and push the eyes towards the opposite side.
Opposite side, yes,
So
sir.
supranuclear gaze palsy can be overcome by vestibular stimulation, whereas
Yes, sir.
intranuclear palsy
Nuclear
cannot be
cannot
overcome
be
by
overcome.
vestibular stimulation. Very, very important point. So
Yes,
two
sir.
points to differentiate from supranuclear gaze palsy from infranuclear ocular motor nerve is that in infranuclear ocular motor nerve palsy, there is diplopia, whereas if it is supranuclear gaze palsy, there is no diplopia. Then
Yes,
the
sir.
movement, the restricted movement of supranuclear gaze palsy can be overcome by
Can be
vestibular
overcome.
stimulation, but the intranuclear muscle involvement cannot be overcome by
Cannot be overcome.
vestibular stimulation. Okay.
Sir, sir.
Yeah.
Sir, then there was no history of contracture or exercise
Why did you
intolerance.
ask this history of contracture?
So to rule out congenital myopathy, sir. In generally congenital myopathy, there will be presence of contractures.
What congenital myopathy?
Congenital myopathy, this congenital contractile protein problems like DMD or BMD.
No. What disease, muscle disease, which physically produces contractures?
Generally seen in,
MBD
sir,
refers muscular dystrophy.
macular dystrophy, sir. Muscle
MBD
dystrophy,
refers muscular dystrophy. Bethlehem myopathy. These are specifically produce contractures.
contractures.
Okay, fine.
So then, sir, no history of exercise intolerance. That
What does this mean? Exercise intolerance.
so generally this storage disorder or metabolic myopathy, they produce, sir, this exercise intolerance or that second wave phenomenon.
What is second wind phenomenon?
Sir,
It is second wind phenomenon,
initially,
not wave phenomenon.
second one, sorry, sir.
Yeah, what is second wind
Initially,
phenomenon?
they will have difficulty. Then after that, they will acclimatize. They will not feel weakness.
Yeah, some diseases like McArdle's disease,
Myocardal
myophosphatase
Pompe's disease,
deficiency.
yes, sir.
You have type 1 fibers, you have type 2 fibers. Type 1 muscle fibers are responsible for using oxidation pathways, and they are
Oxidation.
responsible for fast movement, the sprint, the fast movement. But slow sustained movement is done by type 2 fibers, which do not require oxidation. They use other pathways.
Other pathways.
In McArdle's disease, when they do exercise, they have problems because the exercising muscle needs energy, does not get. So once they take rest and then they start again exercising, they can do better because they
Better.
switch over to lipids. They switch
Other
over,
pathway.
fatty acid oxidation.
Fatty acid
Therefore,
beta
they can
oxidation.
do better. This is known as second wind phenomenon. One, regarding muscles, you told very well about the exercise intolerance. Can any autonomic disturbance produce exercise intolerance?
Autonomic dysfunction
Yeah, autonomic dysfunction. Does it produce exercise intolerance?
can produce, sir, if there will be accumulation of acetylcholine in neuromuscular junction.
Yeah.
Lambert, also, no.
See, I'll tell you one thing. The parasympathetic basically has to do with the heart rate or pulse.
Pulse.
Sympathetic pathway is basically to do with the blood pressure. Okay.
Yes, sir.
Okay. So you have two components, parasympathetic and sympathetic.
Sir.
When we are at rest, the pulse rate is normal.
Normal.
It starts increasing only when we start exercising, right?
Exercise. Sir.
If our parasympathetic system is good. But if our parasympathetic is dysfunctional, even at resting stage, when there is supposed to be normal rate, since the parasympathetic function is affected, there is no control of parasympathetic or the heart rate. So there will be tachycardia.
Resting tachycardia.
Yeah,
Yes,
you call that as resting tachycardia.
tachycardia.
So resting tachycardia indicates a parasympathetic dysfunction.
Dysfunction, yes, sir.
Okay. Likewise, when you are at rest, the muscles function normally, you have adequate blood. But when you exercise, the heart has to increase the heart rate. The blood pressure also should increase so that the muscles get extra blood because they are exercising, they need extra nutrients. But normally when we exercise, the blood pressure shoots up, so muscles are able to tolerate the exercise. But if there is sympathetic dysfunction, the blood pressure does not shoot up, does not increase, and when they exercise, they become breathless because oxygen to the muscles is insufficient. So
Sufficient.
resting tachycardia indicates a parasympathetic dysfunction,
Sympathetic.
and exercise intolerance indicates a sympathetic dysfunction.
Sympathetic
Sympathetic system is not able to increase the heart rate and the blood pressure, and
to
therefore
the
they
muscle.
cannot tolerate exercise. Okay, so much
Yes, sir.
of information you can get by this exercise
Exercise
intolerance.
to
Yeah,
that. Sir. So
yeah.
there is no history of cola-colored urine also that is seen in
Tell-
generally
Yeah,
enzyme deficiency like phenylketonuria and other diseases like that metabolic glycogen storage disorder and phenylketonuria we see
yeah.
generally cola-colored urine.
Okay.
Enzyme
So
myopathy. Okay.
basically,
So there
when this looks more like a muscle disease.
muscle disease, yes, sir.
So
Acquired muscle disease mostly due to either inflammation or infection.
this has been going on consistently last three
Yes, sir.
months, or is
Last
it
3 months.
intermittent? Or is it intermittent?
No,
Comes
sir.
and
It was the weaknesses are going on, sir.
yeah, because when you're talking about exercise intolerance, you need to know one thing. You need to ask yourself whether it is a persistent muscle weakness or an intermittent muscle weakness where it
Intermittent muscle weakness.
comes and
Yes,
goes.
sir.
So what are the conditions which produces intermittent muscle weakness? So between the episodes, they are normal. What are those conditions?
The channelopathy, sir.
Very good. One is channelopathies, hypokalemic periodic paralysis,
Hypokalemia,
calcium
hyperkalemia.
channel disorder. Okay. Then
And sir, periodic pulses like uh, neuron involvement in CIDP like that. They can also have
now you
periodic pulses.
know metabolic myopathies, the
Metabolic myopathy, yes,
glycogen
sir.
storage diseases or
Glycogen storage disorder.
lipid disorders, fatty acid utilization disorders,
Practices.
they also occur intermittently. So when they take rest, they become better. So they also occur intermittently. And what is the third? NMJ disorders,
Neuromuscular,
muscular junction disorders, myasthenia gravis.
neuromuscular junction disorder,
So
yes,
when
sir.
they take rest, they become all right. So
Yes, sir.
three important conditions which present as intermittent weakness are neuromuscular
Channelopathy,
junction
neuromuscular
disorders,
junction,
channelopathies, and
enzyme,
yeah,
metabolic,
metabolic disorders
metabolic.
like
Yes, sir.
like glycogen or
Glycogen
lipid
storage disorder, sir.
fatty acid
Lipid.
oxidation disorders. Okay,
Yes, sir.
fine.
And so there is no history of dry cough or shortness of breath or cutaneous calcifications.
Why did you ask this history? Why did you ask this history?
These are actually this dry cough, shortness of breath. They are generally associated with this interstitial lung disease, which is seen in dermatomyositis, sir. And calcinosis culosis also seen in dermatomyositis, sir.
Very good. Because these disorders can be associated with the interstitial lung disease. So you
Interstitial
have
lung
asked
disease.
for history of dry cough. Very good. Nice. Carry on.
So there is no history of dysarthria.
Why did you ask history of dysarthria?
So to check for the involvement of uh, this bulbar cranial nerve involvement, which are involved in speech or any language.
What
Cranial nerves.
cranial nerves will produce dysarthria?
Sir, it can be due to bulbar 9, 10th, 11, or it can be dysarthria can be due to tongue involvement. That can be due to 12th also. So 9, 10th, 11, 12th. And sir, due to 7th also, we can have dysarthria due to
Very
the
good. Very
lapis
good.
pop due to facial movement. We can give dysarthria due to
Yeah,
7th,
you
9, 10th,
have,
11, and 12th also.
yeah, ninth is basically sensory. So
Special
basically you have labial component,
labial component,
lingual component,
liquid,
palatal component.
palatal,
Labial component means you use lips.
lips,
So pa, you have to
paw,
use lips. So
lips,
orbicularis oris, that means
all
seventh nerve.
those.
So if
7th, maybe 7th,
now gets affected, the labial component gets affected,
labial
it
component,
produces dysarthria. The tenth component, tenth nerve is responsible, vagus responsible for palatal movement. So if
palatal is
tenth nerve gets affected, palatal movements get affected. They can't say ka. And the tongue,
tongue,
genioglossus, the movement, if that gets affected, they cannot, if tongue gets
tongue,
affected, they cannot move the
tongue,
tongue. So the lingual component gets affected. So this is supplied by 12th nerve.
12th
So
nerve, yes, sir.
11th nerve causes labial component getting affected. 12th
10th.
causes lingual component getting affected. 10th nerve causes spinal component getting affected. So by simply using one sentence, pataka,
Vataka, yes, sir.
we say in Tamil pataka. Pataka means to see. That's how I remember. Pa means lips. Ka
Pa,
means tongue. Ka
tongue,
means okay. So
yes,
these
sir.
also produce
Vataka.
dysarthria. So by asking for history of dysarthria, you can find out whether these cranial nerves are involved or not. And another nerve which indirectly may cause dysarthria is trigeminal nerve, because trigeminal nerve
Right.
is the movement of the muscles of mastication.
Pterygoid, yes, sir. Pterygoid
Yeah.
involvement.
You need jaw movement also. So if the
Jaw
jaw movement
movement,
is
yes,
also not well, they can also produce dysarthria. So, so trigeminal nerve also indirectly can cause dysarthria. Of course,
sir.
the most important is cerebellar peripheral, because it is responsible for balance. It coordinates. So if that gets affected also, you get dysarthria. You can get scanning type of speech. Okay, right. So basically, you want to know whether cranial nerves are affected.
Cranial.
So you ask history of dysarthria. Very good. Yeah. Then
Then, sir, no history of any abnormal movements in any part of body. So this
why
is same as fasciculation.
of abnormal movements?
Sir, same as fasciculation only, sir. I have repeated this one to rule out this fasciculation. And other spasm or contracture, there is not there.
See, abnormal movements, there are basically two types, involuntary movement.
Fasciculation, fibrillation,
Yeah, no. How we approach is that hypokinesia or hyperkinesia.
hyperkinesia. Yes, sir, hypokinesia.
Hypokinesia, the classic example is Parkinson's disease.
Parkinson disease.
Hyperkinesia examples are chorea or
Chorea,
dementia.
athetosis, this is the.
Many are there.
Yes,
So
sir.
basically, if you see, very interesting is that a chemical substance is responsible for all this, which affects the circuits in the basal ganglia.
Movement disorders, yes, sir.
That is dopamine.
Dopamine.
Dopamine, everything should be in the optimum, neither too much nor too less. So when the
Okay, sir.
dopamine is in the optimum state, we have normal movements.
Yes,
When
sir.
dopamine is decreased, like Parkinson's disease, we have hypokinesia, decreased
Hypokinesia, yes,
movement.
sir.
When the dopamine is in excess, like chorea, we have excessive movements. So
Excessive.
dopamine is responsible for kinesia. It should be in
Correct.
the optimum level. Low dopamine, hypokinesia, high dopamine content, hyperkinesia.
Hypertension.
And another important function of dopamine is to keep your pleasantness of your mind. It gives
Mind
happiness.
is psychosis
So
and
when the
happiness.
dopamine gets decreased, you have not only hypokinesia, but also
Yes.
depression.
Depression, yes, sir.
That's why they are depressed. Whereas
Depression.
if dopamine is in excess, not
There
only
is
they produce
psychosis.
excessive movement, they produce excessive happiness to the extent of
Hap-
mania and hitting others.
Mania
Classic
and
example is
disease.
schizophrenia. In
Schizophrenia.
schizophrenia, there is dopamine excess.
Excess.
In Parkinson's disease, there's dopamine deficiency.
Deficient.
Because of dopamine deficiency, they are depressed and there is hypokinesia. Okay. So that's how you ask about history of abnormal movements. Very good.
No
Okay.
abnormal
Right.
movement. So no history of change in voice, quality of voice, and no history of bladder or bowel incontinence.
This is very important history. Why is this important history? Why did you ask for no bowel bladder incontinence?
So autonomic dysfunction, sir.
Not only autonomic dysfunction, perhaps you're talking about upper limb involvement, lower limb involvement. We are still not sure whether it is
Spinal
only
cord.
bowel or it could be spinal cord also. Very good.
Spinal cord, yes, sir.
So
True love spinal
spinal
cord.
cord can cause bowel and bladder disturbance.
Bladder
The moment
involvement also.
say there is no bladder disturbance, you have almost
Rule out
convincingly ruled out a spinal cord disorder.
spinal cord
Okay,
involvement.
because spinal cord also, in fact, cervical spondylosis
It's a high
may
cervical
present
compression.
with lower limb weakness, not just upper limb.
Weakness.
Initially,
Yes.
actually, you see cervical spondylosis, they present with gait disturbances. Why it
Yes,
presents
sir.
gait disturbances more than upper limb disturbance? Cervical region. Cervical means upper limb should get affected, no? But we say that they present more with gait disturbance, lower limb involvement. Why?
The posterior columns that are placed that cervical is internally placed, but the upper fibers of the for lower limb they are placed outside. Maybe for that reason,
Yeah.
sacral fibers are placed
Corticospinal
more.
tract fibers, this is to do with movement. So we are talking about
Yes, sir.
corticospinal tract fibers.
What you see TLS like
Corticospinal tract fibers, here in cervical region, it is placed outwards. So anything
outwards.
goes and hits first, the lower limb fibers are affected, then the upper limb fibers. Okay.
Okay.
What is mirror movement?
Mirror movement.
Especially when we talk about CVJ anomalies or lower brainstem and upper cervical cord, we'll be talking about mirror movements. What are they? Arnold-Chiari malformation, syringomyelia, we'll be talking about mirror movements. What are they?
So the pattern of weakness, fast, that is the Ellsworth phenomenon. Mirror movements, I don't know.
See, corticospinal tract crosses at the level of the medulla oblongata and goes to the
Yes, sir.
opposite. Okay.
Opposite.
See, cortico, if you see starting, the lower limbs are medially placed because the leg area is here, but
Yes,
the
sir.
upper limb fibers are laterally placed. So lower limb fibers are medially placed and upper limb fibers are laterally placed. So the lower limb fibers which are medially placed, as they cross in the medulla oblongata, they become lateral. That's why in cervical spondylosis, when it hits the lower limb fibers first. They can present with gait ataxia. Okay.
Great attacks.
And,
Okay.
yeah. And so when they cross like this, you have
Yes, sir.
more than 80 to 90% of the fibers crossing, but 10 to 20% of fibers don't cross. So this crossing occurs at the level of the medulla oblongata and the upper cervical cord. So if there's a lesion, anything like syringobulbia or Arnold-Chiari malformation, it affects both the crossing and uncrossing fibers. They can have haptic connection between crossed and uncrossed corticospinal tract fibers. So these produce mirror movements. So what are mirror movements? So the crossed fibers, when I want to lift my left hand upwards, I'm using my right corticospinal fibers, which have crossed to the opposite side. But if there's Arnold-Chiari malformation or syringobulbia at the level of the medulla oblongata and cervical cord, there can be a haptic connection between uncrossed corticospinal fibers and crossed corticospinal fibers. So when I lift this left hand upwards, my right upper limb also goes upwards. These are known as mirror movements because there's an haptic connection between crossed and uncrossed corticospinal fibers. So if you find mirror movements, that means it is at the level of the brainstem and the cervical cord lesion. Okay, so mirror movements occur in brainstem lesions.
Sir, just can you please repeat the what type of movements in mirror movements? Actually, I got disconnected maybe due to internet. What are the movements?
Yeah. Mirror movements occurs at the lower brainstem.
Yes, sir.
You can see this in craniovertebral junction anomalies. CVJ anomalies, very common. Arnold-Chiari malformation or Klippel-Feil syndrome, wherein there's an haptic connection between crossed corticospinal tract fibers and uncrossed corticospinal fibers. So there's an haptic connection. So once if you lift one limb upwards, example, left upper limb upwards, the right upper limb also goes upwards. So it is mirror movement. Exactly, it mimics the other limb because of the haptic connection between crossed and uncrossed corticospinal fibers. So it indicates that there's a problem in the lower brainstem, upper cervical cord lesions. Example, CVJ anomalies like Klippel-Feil syndrome,
Syringomyelis,
syringobulbia, or Arnold-Chiari malformations. Okay,
I'm not
right.
sure. Okay, sir. Sure. Sir, then, sir, there was no hearing difficulty to rule out some kind of myopathies like mitochondrial myopathy, Counsellor myopathy. There is hearing difficulty also, and you can rule out the involvement of eighth cranial nerve also. Then there
No.
is no imbalance or swaying while walking to rule out ataxia and cerebellar involvement. Then, sir,
What's the
no,
problem with cerebellum? How does it exactly gives you balance?
sir, like
Cerebellum is known as coordinator.
coordination. Yes,
It
yes.
coordinates. It is otherwise known as comparator also. It compares. Basically, if I want to perform a work like lifting my pen, this is known
It have
as
to be coordinated.
intended movement. Intended. I intend to perform.
Intended. Yes,
This
sir.
is known as
Intended.
intended movement. So
Yes.
this afferent information to the cerebellum comes from the frontal lobe through a tract known as frontopontocerebellar fibers.
Cerebellar tract, frontal cerebellar.
So this is for intended movement, the information comes. But the actual movement, which I have already done, like lifting the pen, comes from the spinocerebellar fibers. So intended movement, what I want to do, frontopontocerebellar fibers, the actual movement is the spinocerebellar fibers.
Spinal cerebellar.
Cerebellum now compares these two. Is the movement, intended movement, and the actual movement are correct, are in unison or not? If it is not there, it has to adjust and then make it perform again. So it compares these two movements, and if it thinks it is correct, it sends the information back from the cerebellum to the frontal lobe through a
Yes,
tract
sir.
known as dentatorubrothalamocortical.
Thalamic tract.
So intended movement frontopontocerebellar fibers, actual movement spinocerebellar fibers after comparing the information sent back through dentatorubrothalamocortical tract. And why the cerebellar findings are on the same side, why not on the opposite side? If the left
Due to the,
cerebellum
sir,
is
there will be
affected,
double decussation of the spinocerebellar
very
tract.
good. For example, left cerebellum is affected, dentatorubrothalamocortical tract goes to the right side cortex.
Right side.
Finally, everything has to act through the corticospinal tract. It descends back and crosses again corticospinal tract at the level of the medullobulum. Because of this double decussation, cerebellar findings are always on the same side. Okay.
Same.
Okay.
Then, sir, there was no early morning stiffness to rule out rheumatological diseases, arthritis, sir, inflammatory
Very good.
arthritis,
These are usually associated with the connective tissue disease like rheumatoid arthritis. You are trying
rheumatoid
to
arthritis.
rule out interstitial lung disease by asking dry cough. Good. They can sometimes
Then,
be
sir,
with cancer. You should ask about weight loss, other
weight
things also.
loss. Yes.
Paraneoplastic. Yeah.
Paraneoplastic syndrome.
Yeah.
But there is no history of rashes, no alopecia, no oral ulcer to rule out systemic lupus erythematosus, SLE, no history of any trauma, no history of headache, loss of consciousness.
Why did you ask about history of headache, loss of consciousness, seizures?
Hello. To rule out some any intracranial cause or in cortical involvement that can cause headache or loss of consciousness or seizure.
Yeah.
Like there are causes of cortical paraplegia. There is no causes of cortical quadriplegia as such. But
Very
still to
good.
rule out
Now, paraplegia means lower limb, just not spinal cord. Even cortex can cause
cortical is
paraplegia because, as I said, the lower limb fibers start from the medial part of the frontal lobe, supplied by the anterior cerebral artery. So, bilateral anterior cerebral artery involvement or any venous sinus involvement can cause paralysis. And but you know one thing, the brain has got no pain receptors.
yes, sir.
Brain has got no pain receptors.
Okay,
You
sir.
cut brain, there is no pain.
Okay.
That's why you see so many stroke patients. They don't complain of headache.
Yeah, yes, sir.
Headache is seen only in three conditions, basically. You see it in subarachnoid hemorrhage. You see it in meningitis. You see it in migraine. You
Yes, sir.
don't see it in intracerebral hemorrhage or intracerebral infarct. You know why? Because brain has got no pain receptors. It is only the
Okay.
meninges and the vessels in the meninges which are pain sensitive. That's why only when the meninges get affected or vessels in the meninges, you get pain. That's why you get pain in subarachnoid hemorrhage because arachnoid meninges is affected, you get pain.
Meninges are irritated.
You get pain because meninges is affected. Migraine, you get pain. Trigeminal system again.
Trigeminal, yes, sir. Trigeminal
Trigeminal
nerve.
nerve gets affected. Okay, good, sir. Okay, carry on.
Then, sir, history of past illness. No such similar illness episode in past. She is not a known case of diabetes or hypertension or any asthma or any thyroid or autoimmune diseases. And
Okay,
sir,
good.
no history of any malignancy in past,
This
sir.
is very important. I was looking for this. Good. Because malignancy, you should always ask, especially when you're suspecting inflammatory myopathy.
Malignancy.
Okay.
Paraneoplastic syndrome. Sir, family history, born out of a non-consanguine marriage, no similar history present in our family. Then personal history, belong to lower socioeconomic group, studied up to 10th standard, unmarried, takes both veg and non-veg diet, no addictions, bladder and bowel habits are regular. Then sir, treatment history, she was treated locally at a physiotherapy center and received some medications. And now she is admitted to female medicine ward 2 and Department of Medicine in SCV Medical College from 10th April and was receiving treatment of tablet prednisolone 40 milligram one tablet daily and the injection pantoprazole and injection ceftriaxone. And the neck drop she was having initially and the arthralgia and the dysphagia subsided, but the weakness is still present. Then, sir, summary of the history, sir. Sir, a 22-year-old female.
22 is very important. Okay.
Yes,
That
yes,
means
sir.
she is a young person.
Young.
Okay. Some diseases are seen in young, some diseases are seen
Some
in old patients.
person.
Most of the autoimmune disorders are seen in young and women. The
Young
women,
woman.
you see, autoimmune is more common than the male gender, and you usually see in the middle aged. Okay. So this fits in for an autoimmune criteria. It gives me good information. It's at 22 years, not very old, and she's a female. Okay, right.
So
So
she
this gives
presented with
me like an autoimmune, right? Okay.
yes, sir. Presented with insidious onset, progressive weakness in the both the upper limbs. Initially,
Insidious onset and progressive. This is what I was asking you. Progressive weakness. Okay. So it is not intermittent, progressive weakness. So the
progressive
moment it is progressive, you have ruled out three conditions. Channelopathies, which are
and
produce intermittent weakness,
neuromuscular junction
myasthenia gravis, which produces intermittent weakness, and metabolic
and
disorders like
metabolic disorders.
glycogen storage disorder, fatty acid oxidation. You have to rule out those conditions.
All those
Okay.
concerns. Progressive weakness in both the upper limbs, initially proximal to start with, then distal, and
So
progressive
again, proximal more distal. So it
more
looks
than
like
distal.
myopathy. Okay.
Apathy, yes, sir. Then in the weakness in both the lower limbs, that is also proximal more than distal, with truncal, neck, and esophageal muscle weakness, with no sensory
So no
involvement, no
sensory
bladder.
involvement. So no sensory involvements. You're ruling two conditions. One, peripheral neuropathy, you're ruling out.
Yes, sir.
Second, spinal cord disorder also you're ruling
Spinal,
out. Okay, good.
even from the no bladder valve involvement also
Again,
rule
you're
out the
ruling out spinal cord disorder.
spinal
Okay.
cord, with history of intermittent fever, myalgia, and arthralgia to add inflammation or infection.
So yeah, very good.
Inflammation mostly.
Fever means and myalgia, arthritis, joint pains are there. So you're thinking of an inflammatory condition. Good.
Inflammation.
Fever is also there. So now it looks like a muscle disease. Why?
Muscle.
Proximal muscles are involved more than the distal muscles, at least initially. It is a progressive type of muscle weakness.
Progressive.
There is no sensory involvement. So it is no peripheral neuropathy and no spinal cord involvement. And yeah, no bowel and bladder involvement.
No
And
bladder
of
valve.
the myopathies, you think more of inflammatory conditions, especially
Inflammatory
autoimmune,
condition.
because of her
Yes.
age, because of her gender, and because of symptoms like fever, myalgia,
Fever.
and arthralgia.
Myalgia.
So, what are your thoughts? These are my thoughts. What are your thoughts?
Sir,
What are your thoughts? What do you think at the end of the summary? What is
sir,
your
this is a
differential diagnosis?
sir, this is typically sir myopathy only. So it can be inflammatory myopathies. We can think of dermatomyositis or myositis and inclusion body myopathies. But inclusion body is generally seen in old adults, and that has a distal in upper limb and proximal in lower limb.
Yeah, very good.
It
See,
can
if you
it
see,
can be a mitochondrial myopathy also, but there is no history in family. No mother is affected. It can be sir limb girdle muscular dystrophy also, where there, but that is generally seen in young age, in fast decades, sir, 8 to 15 years. And it can also be there is a, it can be a DD, but we have ruled out like that a condition limb girdle type of myasthenia gravis also, sir, is there. And there also there will be proximal involvement, but there will be the features of neuromuscular junction involvement.
okay.
So the
If you think more of inflammatory myopathies, it should be
myopathy,
there. It could be either polymyositis, dermatomyositis, inclusion body
inclusion
myositis.
body myositis,
Common is there is no skin lesions,
no skin lesion.
probably dermatomyositis. What are the skin lesions you see in dermatomyositis?
Sir, we get heliotrope surrounding the edema and the eye, and sir, Gottron papule and Gottron sign, and sir, salt and pepper rashes, V sign and Sol sign in the back, and in the thigh we get that holster sign, sir.
And you get dilated capillaries in the nail
That is a
fold.
nail, is nail
Yeah,
capillary.
very good. And second thing, inclusion body myositis, it is more commonly seen in males as compared to
It's
females.
almost, yes, sir.
Generally, as I said, autoimmune disorders are more common in women,
In female,
but inclusion body myositis is more common in men as compared to
more
women.
commonly,
It is
yes, sir.
usually seen more than 50 years old.
More
Okay.
than 50
And very classically, it affects the flexors. It
flexors, yes,
affects
sir.
the wrist flexors, that is the distal muscles of the of
Distance of upper limb and flexor,
biceps
proximal support,
muscles. So it affects the quadriceps of the lower muscles. So they have difficulty in extension of the knee,
extension of the
quadriceps, because quadriceps affected, quadriceps is responsible for extension of the knee. So again, very interesting. You can ask history of walking backwards, whether it is
working
easy,
backward.
walking backwards, whether it is easy or difficult. What condition will produce difficulty in walking backwards? What condition will make walking backwards easy?
So backward, walking difficulty backward means if there will be hamstring muscle problem, so there will be difficulty in flexion.
No, this is what I'm talking about. Inclusion body myositis.
Oh, sorry,
Inclusion body myositis, the quadriceps is affected. So they
quadriceps
cannot
is affected.
extend the knee. So they find it difficult
Quadriceps is for extension of the yes.
forwards. They find it difficult to walk forwards. they find it easy to walk backwards because
Backward.
they're
Okay,
not
sir.
using quadriceps. So walking backwards will be easy for persons with quadriceps weakness, example,
Quadriceps weakness.
body
Yes, sir.
myositis.
So,
Okay.
yes, sir.
But walking backwards will be difficult for persons who are having posterior column lesion because
Posterior.
the balance is basically done by three systems. One, the ocular system. Second, the vestibular system. Third, the
Yes, sir.
posterior column system.
Yes, sir.
If these three systems are functioning well, you will have a perfect balance. But even if two systems are functioning well, you will have a reasonably good balance. But if only
Yes,
one
sir.
system is functioning well, you will lose your balance. So if your ocular system is good, your vestibular
Vestibular
system is good, your posterior
with
column system
posterior
is good,
column.
you have perfect balance. But
Perfect.
imagine if your posterior column is affected, like syphilis, neurosyphilis, where the posterior column
Neurosyphilis.
is affected.
Posterior column.
So you are
Damage
dependent
percent.
on two systems, one the
Two
ocular
system, one
system,
ocular
second
and
vestibular system. But they
oral.
are enough for you to have a balance. But the moment you close your eyes, you are removing the second system also off,
Second system.
so
Yes,
you
sir.
fall. That is the basic
Rhombox,
of rhomboxane.
rhombox and
So
vascular
rhomboxane, basically, the second system also you're removing by closing your eyes. So
closing eyes.
persons who are having posterior column lesion, they
Okay.
depend on ocular and vestibular.
Ocular and vestibular, sir.
Extra. So when you ask them to walk backwards, they are not able to see what's happening backwards.
What's happening?
So you're removing the second system also. So walking
Hmm.
backwards will be difficult for persons with posterior column lesion. You got it?
Posterior column.
So walking backwards is easy for persons with quadriceps weakness,
Quadriceps difficult, yes, sir.
but walking backwards will be difficult for persons with posterior column lesion.
Posterior column.
So quadriceps is affected in inclusion body myositis,
Inclusion.
wherein quadriceps is affected and the wrist flexors are affected. Distal
Okay.
muscles of the upper limb and proximal muscles of the lower limb. Okay, very nice summary. Good. Carry on. So this looks more like now a muscle disease,
Myopathy. Muscle disease.
probably inflammatory myopathy at this
Myopathy.
stage.
Yes.
Will confirm with your examination findings.
Sir.
Yeah.
Sir, general examination, thin body build, length was 152 centimeter, height was 34 kg, making a BMI of 14.7 kilogram per meter square. There is a mild pallor, no icterus, no cyanosis, no clubbing, no pedal or enlarged lymph nodes. JPP was not raised, no thyromegaly. Skin hair conditions were perfectly normal. No neurocutaneous markers were
Why you
present.
are asking about neurocutaneous markers? Why is it important always to ask about neurocutaneous marker, especially in
So, to rule out the syndromes, sir, tuberous sclerosis, neurofibromatosis, telangiectasis.
why they should have skin involvement, these disorders? They are primarily neurological disorders, no? Why should they have skin manifestations and you are talking about neurocutaneous? What is the mechanism?
Sir, due to sir, the genetic, the sonic head of
The congenital problems usually they
congenital
manifest on
congenital
skin. Why? Because skin and brain both
brain,
originate
ectoderm,
from ectoderm.
ectoderm is the
So
sonic head of
ectoderm
the
gives rise to both brain and skin. So
skin.
usually if there is any congenital lesion where there's a problem with ectoderm, not only the brain, the corresponding findings may be seen on the skin also.
Skin also is
So any neurological condition, especially in young age, you should always talk about neurocutaneous marker and
cutaneous
skin involvement because both skin and brain originate from the common ectoderm. Okay.
ectodermal origin is. Then, sir, she was having some acne on her face of grade 2 and grade 3, and there was a presence of dressing over the right thigh. That was due to we have gone for the muscle biopsy in the vastus medialis. That dressing pad was there. Then, sir, pulse was 88 beats per minute, regular, normal in volume and character. No brachiofemoral delay, no radial delay. Atrial valve was just palpable, and all peripheral pulses are well felt. Blood pressure measured in right arm supine position was 114 over 76 millimeter of mercury. Respiratory rate was 18 per minute, regular abdominal thoracics, and temperature was
What is
measured
the
as 98.
simplest bedside test to find out whether there's autonomic neuropathy or not?
Sir, mm, orthostatic hypotension, sir, or we
Very
can
good.
say abnormal
Very
sweating,
good. You measure blood pressure on lying down. Ask
lying
them,
down, and
and after 3 minutes, again you'll
out
measure the
3
blood
minutes.
pressure. If the fall is more than 20 systole and 10 diastole, it
10
suggests
distilled after 3 minutes.
hypotension.
Yes, sir.
Simple way of finding out whether the asking person is having autonomic neuropathy or
Autonomic
not.
dysfunction.
When you're asking history, you should ask about uh, two things. One, exercise intolerance. Second is
So,
resting tachycardia. Okay.
testing technique.
So you can
Abnormal
confirm
sweating.
with your pulse. Yeah.
Yes, sir. Then, sir, examination of nervous system, higher mental function. Patient was conscious, well oriented to tankless person. Speech is normal. normal memory and intelligence, no delusion or hallucinations.
See,
Sir,
basically, memory, everything is to do with the hippocampus.
memory
Okay.
hippocampus. Okay.
You have immediate memory, recent memory, long-term memory. You have implicit memory. You have explicit memory.
Explicit memory.
What is implicit memory? What is explicit memory?
Sir, implicit that generally we remember by doing with activity we remember.
Implicit memory, you don't need conscious recall.
Consciousness, yes, sir. We don't need
Putting
consciousness.
a lot of effort to master it, but once you have mastered it, it becomes automatic.
Automatically, sir.
Example is the procedural memory.
Procedural memory, yes, sir.
What is procedural memory?
Sir, by repeatedly doing that
For example,
activity,
you have two types of memory. You have classical conditioning, you have procedural memory and implicit memory.
yes,
Procedural memory is that, for example, just because you're born as a human being, you will know how to walk at,
what
say,
is
1.5 years, how to talk at 3 years of age. It is inborn. But
inborn
driving a car, swimming, cycling, they are not
cycling
inborn.
is
You put a lot of hard work and
effort,
then
and
master
then
it,
we
and
learn.
it becomes automatic. For
Hmm.
example, some may know swimming, some may not know swimming.
Man
But
not
just
saying.
because we are all born as human beings, we all know how to talk, how to walk. So these events where you they are not inborn, where you have to put in a lot of hard work and master it, they are known as procedural memory. The
Procedure
beauty of procedural memory is that it becomes automatic. Once you know
automatic.
swimming, suppose I
We
push you in
can, sir.
water, you will not think how to put my right hand or how to put my left hand. It becomes automatic. Suppose you know car driving, I give you car key, you immediately drive the car and go. It becomes automatic. There's no conscious recall. Likewise, classical conditioning. You must have heard of Pavlov's experiment. The dog,
Pavlov's experiment, that
they ring the
salivation,
bell,
yes, sir.
they serve the food. So once
Yes,
they
sir.
ring the bell, the dog anticipates foods and it starts
Foods
salivating.
are common, yes,
But
sir.
once they, after a few episodes, they rang the bell, they didn't serve the food, it's just salivating.
Salivation of secretion, yes, sir.
Condition. Again, it is
Classical condition,
automatic. It is not thinking that I
automatic,
have to salivate. So
yes, sir.
classical conditioning is in cerebellum. That's why
Cerebellum,
even if the hippocampus gets affected, they can carry on with their daily activities. The explicit memory you need conscious recall, like semantic memory and episodic
sem-
memory. Suppose I ask
semantic,
how brachial plexus is formed, you think and then answer. That
yes,
is
sir.
semantic memory. Suppose I ask where you went last year to Tirupati, did you go to Tirupati or did you go to any other
Remote
place?
memory.
You think in an episodic memory.
Episodic memory, yes, sir.
Memory and semantic memory are explicit memory. Procedural memory and classical condition are implicit memory.
Implicit,
And
yes, sir.
though in most of these things, hippocampus is involved, but procedural memory, hippocampus is not involved. Therefore, like there's one person called Mr. H.M., Henry Morrison. They removed his hippocampus, temporal lobectomy to control his seizures. He lost complete memory, but he was playing golf. That means temporal lobe is not responsible for procedural memory. Cerebellum is
Procedure,
responsible. Though he lost all memory, he was playing golf. So
playing golf.
procedural memory, it is not to do with hippocampus. Okay, carry on. No delusion, hallucination.
Okay. Then, sir, examination of cranial nerves. Sir, all the cranial nerves were normal, sir. Only during examination we found difficulty in shocking of soldier. That is due to muscle involvement, sir.
Yeah.
Olfactory nerve normal, sir. No anosmia, no parosmia. Optic nerve was normal bilaterally. Fundoscopy was normal. Oculomotor, no ptosis, no extraocular movement involvement. All the extraocular movements are normal. Pupils are normal in size and shape in both eyes. Light reflex were both direct and consensual reflex were present, and accommodation reflex was present. And so trigeminal nerve sensation over the face were normal. Corneal reflex present in both sides. No weakness of muscle of mastications. In jaw jerk not elicited. In facial nerve, no weakness of facial muscles. Taste sensation over anterior two-third of
Okay.
the tongue was intact.
If fifth nerve were to get affected or seventh nerve were to get affected, the movement will be towards which side?
Sir,
Fifth nerve gets
actually,
affected, the jaw will move to which side?
sir, in 10th and 7th, we get opposite side, and in 12 and 5, we get same side, sir.
Very good. It is known as rule of 17.
Rule,
12th
rule
nerve
of 17, sir.
glossus pushes towards opposite side.
Opposite
Fifth
side.
nerve pterygoid pushes the jaw towards the opposite side. So if 12th nerve and fifth nerve gets affected, the movement will be towards the diseased side. Whereas
Disease
if
side, yes, sir.
10th nerve palate moves towards the healthy side, 7th nerve moves towards the healthy side. So if these get affected, the movement will be towards the healthier side.
Healthy side, yes, sir.
10 plus 5, they get affected, the movement will be towards the disease side. 10th and 7th now gets affected, the movement will be towards the healthier side. 10 plus 7
Healthier
is
side, yes, sir.
12 plus 5 is also 17, rule of 17.
So,
Good. Carry on.
Then, sir, vestibulocochlear nerve, Rinne's test positive, Weber's test was not lateralized, and glossopharyngeal and vagus nerve, palatal movements were normal bilaterally, and gag reflex was present. Accessory nerve, there was weakness of sternocleidomastoid and trapezius, but that is not due to spinal accessories, but that was due to myopathy, we can say, sir.
Yeah, very one important concept about sternocleidomastoid. Imagine this is sternocleidomastoid.
Sternocleidomastoid, sir.
All cranial nerves, by and large, get bilateral supply, but predominantly contralateral supply. The corticobulbar fibers they get from the contralateral supply, except sternocleidomastoid. Sternocleidomastoid gets a predominant supply from the same side cortex.
Yeah.
That's why once if the cortex gets affected, imagine my on the image you see as the right cortex. If my right cortex gets affected, my right sternocleidomastoid gets affected. So I cannot push the head to the opposite side. Head will be moving to the same side. So in a cortical lesion, it cannot push the eyes towards the opposite side. Eyes will be looking towards the same side. It cannot push the head to the opposite side because same side sternocleidomastoid is affected. The opposite sternocleidomastoid will push it. Hemiplegia will be on the opposite side. So eyes looking to the same side, head looking to the same side, is on the opposite side. It's the frontal lobe infarct. So all cranial nerves have got bilateral innervation, predominantly contralateral, except sternocleidomastoid. Against the rule is that it has got predominantly ipsilateral supply from the corticobulbar fibers.
Yes, sir.
Yeah.
Then, sir, 12th nerve, no atrophy or fasciculation of tongue, no deviation of tongue to any side.
Yeah.
So then motor system examination. Attitude, patient was lying supine in position with both the lower limbs extended at hip and knee. Bulk, patient looks thin built, no visible fasciculations. There was atrophy of supraspinatus and small muscles of hand, overthenar and hypothenar muscles, and the wasting also was seen in dorsal surface of the hand. And coming to bulk, in right arm it was 19 centimeter, in left was 18 centimeter, and in forearm 18 centimeter and 17 centimeter, and in thigh and leg bilaterally 34 and 27 respectively. Then tone, in both the upper limb and lower limb, it was hypotonia, sir.
So
Coming
the
to power,
tone is decreased.
decreased, yes, sir.
Again, suggestive of a muscle disease.
Muscle disease, yes, sir.
Okay, right.
Then, sir, coming to power, sir, proximally around the shoulder joint, there was 2
See,
over
when
5.
the tone is decreased, what will happen to the reflexes? So
It
tone
will
is
decrease.
means LMN lesions. So what will happen to the
LMN
reflexes?
reflexes will, sir, hyporeflexia or areflexia.
Very good. The reflex will be diminished.
Diminished.
Only if the tone is increased, there can be brisk reflexes.
Brisk reflexes.
Okay, so when the tone is decreased, you cannot comment that the reflexes are brisk. They don't go together because this is because of alpha gamma
Gamma. Over. Yes, sir.
alpha gamma co-contraction. Alpha neuron is alpha motor neuron is responsible for power. Gamma motor neuron is responsible for tone. So
okay, sir.
The gamma motor neuron sets the tone for the reflexes to occur. So if the gamma motor neuron is functioning well, the tone is good, there is hypertonia, the reflex also will be good. The gamma, there's no contraction of the gamma motor neuron, the reflex are decreased, tone is decreased, the reflex also will decrease. The reflex cannot be increased. So this is known as alpha gamma co-contraction. Imagine a nice vena string. Only when it is at the optimal length, when you tap it, you will get good music. When it is overstretched, it will break. When it is understretched, it will not produce any sound. So this is known as alpha gamma co-contraction. Okay.
Co-contraction.
So when the tone is decreased, reflexes will be decreased.
It will be decreased.
Increased. When the tone is increased, the reflex can increase. Yeah.
Yes, sir. So these are powers, sir. After power, I'll go to reflex. This is powers. So power around the shoulder joint, proximally it is 2 by 5. And elbow also 2 by 5 flexion and extension, and distally in the wrist there was power of 3 out of 5, and the hand grip was weak.
So you want to say that proximal muscles are more affected than the
more affected than distal.
Okay.
Then, sir, in lower limb also, proximal power was 2 out of 5, and distal was 3 out of 5. So around the hip and knee it was 2 out of 5, and around ankle it was 3 out of 5. And the truncal muscles were weak. He could not get up from the sleeping position, and the neck muscle was also weak. She had difficulty in flexing her neck from getting from lying position.
Okay.
And reflexes, and all the reflexes were absent, sir. Only there was diminished reflex present in the knee.
Hmm. Okay, this is what I said. When the tone is decreased, reflex will decrease.
Reflex will be
This is known as alpha gamma co-contraction.
core
Okay.
contraction.
So Dr. Agasti,
Sir,
you're trying to elicit the reflex. Imagine knee reflex. It is
reflex.
absent. You
Okay.
tried to elicit for 2-3 times, you didn't get it. So as an examiner, I want to find out whether your finding is correct or not. So I've tried to elicit first 1 or 2 times, it has not come, but third time it has come. So if that is the case, what will you think of, especially in this
Sir, we
case?
can first, if it is not coming, we should do the Jendrasky maneuver, sir.
Okay, Jendrasik maneuver again because of alpha gamma co-contraction. By doing
Control,
Jendrasik maneuver or by clenching the teeth, you are stimulating gamma motor neuron so that the latent reflex will become apparent.
apparent. Sir.
It is not present, but after few jerks, after few times you have elicited, it becomes brisk. So what will you think of, especially in this condition, in this case presentation?
Initially absent, after 3 times there is
Yeah,
release.
there is a good reflex response. You were considering NNJ disorder, right, as one of the
Neuromuscular
possible.
junction. Sir.
Neuromuscular junction disease, the reflex will be absent, decremental response. But opposite of that is Lambert-Eaton myasthenic syndrome,
Lambert-Eaton syndrome, yes, sir.
oncogenic carcinoma. This is a
Carcinoma,
presynaptic disorder.
presynaptic
Myasthenia
disorder,
gravis is a postsynaptic disorder.
postsynaptic,
Presynaptic disorder, there's a decrease in calcium release. So the moment you keep on eliciting, the more and more calcium gets released,
calcium
the
deposited.
reflexes will become now
Yes,
apparent.
sir,
It's
yes, sir.
an incremental response.
Yes, sir.
So the reflexes, if it is not present initially, but after some time, after few attempts, when you get the reflex, that means it is more suggestive of Lambert-Eaton myasthenia,
Lambert-Eaton syndrome, yes, sir.
where again the muscle gets affected. There can be autonomic disturbances. There can be usually cancer model like small cell cancer, lung
Non-cell
cancer. Again, that is also important, especially
yes,
in
sir.
this case. Okay, right.
Yes, sir. Then superficial reflexes, plantar was bilateral flexion and abdominal reflex were present. Then cerebellar lines, upper limb could not be done due to severe weakness and lower limb also could not be done. Gait was waddling type, waddling
Yeah.
gait. Was she was
What does this signify? Initially, we were discussing, no? So
sir,
waddling
sir,
gait, what does that indicate?
sir, myopathy is a bilateral gluteus medius and minimus
Very
involvement.
gluteus medius weakness. Good. Abductor. Right. Involuntary
Then
movements are absent.
involuntary movements are absent. It's a sensory examination, as we know from the history, all prime it was there is no involvement of sensor system, and on examination also all primary modalities of sensation like pain, touch, temperature, proprioception, joint
When you
position, and
do
vibrations are
this, primary sensations, did you test cortical sensations also?
Yes, sir, we should do if primary modalities are
No.
intact.
So you could have tested
So actually,
cortical sensations also.
yes, sir,
So,
cortical
okay,
sensor.
fine. I would like to know one thing. For
Sir,
example, the 2-point discrimination is very sensitive on the lips,
yes,
but
sir.
it is not
Width
sensitive on
and
the
back.
eye. Why? Why?
So due to that representation in the cortex, sir,
Very good. Sensory homunculus. If you take that,
sensory homunculus,
yeah, if you take that face and hands, they're having more representation
more
than the or trunk. And therefore, here 2-point discrimination is very sensitive. But here, even if you put 2 points slightly
width,
far away,
yes, sir.
also you can't appreciate. Here you can easily appreciate. Okay. Cortical sensory sensations are normal. You have to test cortical sensations. That means parietal lobe, how it is. But if sensory sensations are itself affected, you need not test because they'll be
Mhm.
also affected. Okay, right. So sensory is normal. So again, it
Normal.
is not peripheral neuropathy, it is not spinal cord disease. It is
Myopathy.
perhaps muscle disease.
Myopathy.
Okay, because sensory system
Then,
is normal.
then, sir, autonomic dysfunction. There is no resting tachycardia or bradycardia. There is no constipation or urinary retention. And skull and spine were normal. No
Why
spinal
you
tendon.
should you are talking about skull and spine, saying that no scoliosis or kyphosis. What is the principle behind it? What is the logic? What is the explanation for looking
Sir,
at the
the
skull and spine?
high cervical cord compression can present as quadriparesis, sir.
But
If
why
there will be
specific
any,
or kyphosis?
sorry, kyphosis
Why
generally occurs, sir,
scoliosis or kyphosis you are asking?
due to
A
the
long-standing, a long-standing lesion, a long-standing lesions like hereditary neuropathy or Friedreich's ataxia, they
yes, sir,
cause
cause
unequal. They cause the muscle weakness is not
muscle.
equal. Okay, so they're not equal. So when there is unequal
Unequal.
weakness of paravertebral muscles or unequal weakness of foot muscles, unequal weakness of paravertebral muscles causes kyphoscoliosis.
Right.
Unequal weakness of foot muscles causes high arched foot. So if
Highest.
there's high arched foot or kyphoscoliosis, they indicate unequal weakness of paravertebral muscles or unequal weakness of high foot muscles. These indicate a long-standing neurological disease, not acute,
Option.
long-standing, like
No.
hereditary motor neuropathy or Friedreich's attacks. But in your case,
Critical.
it is only 6 months. So
6 months.
obviously, there's no scoliosis or kyphosis. No spinal tenderness. You are
No
ruling
spinal
out inflammatory pathology like tuberculosis or
tuberculosis.
anything or fracture, anything in the spine.
Yes, sir.
Okay, good.
Then meningeal signs were absent. Peripheral nerves neither thick nor tender to rule out
Yeah.
that leprosy and all. In sir, examination of other systems like cardiovascular systems are all normal, sir. Cardiovascular inspection, precordium normal in shape, no dilated veins or visible scar marks over the precordium, apical impulse not visible, no other pulsation seen. And on palpation, apical impulse present in the left fifth intercostal space, half inch medial to mid clavicular line, normal in character. Pulmonary area P2 is not palpable, there is no thrill. And on percussion, second left intercostal space resonant, and cardiac dullness starts from the left third intercostal space and does not go beyond the apex.
Why your
Auscultation.
in on cardiac examination so much? Is it important in this case?
Sir, these inflammatory myopathies can cause myocarditis, sir.
Very
And
good. And even
sir,
any hereditary myopathies, anything.
it can cause restrictive
Dystrophy, muscular
cardiomyopathy or
dystrophy is also
dilated
can cause
cardiomyopathy.
cardiomyopathy. Yeah, very good. So
And
you have,
conduction blocks also it can cause, sir.
yeah.
Then, sir, on auscultation, mitral area, fast out sound was normal, no added sound or no murmur. On auscultation of pulmonary area, pulmonary component of second heart sound, no split, no added sound. That means there is no pulmonary artery hypertension also. Then aortic area, aortic component of second heart sound was normal, no added sound and murmur. On auscultation of tricuspid area, fast out sound was normal, no murmur. And neo-aortic area also normal, no murmur. Then sir, on respiratory system, we did respiratory system examination to look for the ILD, sir, interstitial lung disease. Upper respiratory tract was normal. On inspection of chest, trachea appears to be central in position, apical impulse not visible, chest bilateral symmetrical, bilateral chest movements equal on inspiration, and no paradoxical chest movement was there. On
What
palpation,
type
trachea,
of movement you get in men? What type of movement you get in women? Abdominal, thoracic type or thoracic type, and what is the mechanism?
sir, normally in our case, we abdomen thoracic. In female or pregnant, there will be some presence of a fetus in the abdomen. So initially they will try to initiate from the thorax, sir. In female, there will be thoraco abdominal. In pregnant female,
No, respiration depends upon two types of movement. One, intercostal muscles or diaphragm. Men
diaphragm,
depend more on diaphragm, so it is a
diaphragm.
predominantly abdominal type of movement.
Yes,
Women
sir.
depend more on intercostal muscles, so for them predominantly it's a thoracic type of breathing.
Thoracic type.
Perhaps nature wants the women who may become pregnant at later point of time not to use diaphragm, so they have probably from the beginning they are using
Intercostal muscle.
intercostal muscles. Probably it's a nature's way of protecting them. Okay, but whatever may be the reason, women use intercostal muscles more, so it's a thoracic type of breathing.
Thoracic type.
Men use diaphragm for respiration, it's an abdominal type of breathing. But in diseases, it can go either way, irrespective of the gender. For
Yeah.
example, if a man develops peritonitis, he cannot
Peritonitis.
use diaphragm. He'll switch
Diaphragm
over
can
to intercostal
thoracic
muscles.
type.
Becomes a
Thoracic type. Yes.
respiratory or thoracic type of breathing. Suppose
Yes, sir.
women develops pleurisy, they cannot use intercostal muscles. They switch over to
They will
diaphragm,
use
become
diaphragm. Yes, sir.
abdominal type of breathing. So it gives you a clue about the pathology of the disease
Pathology of
also,
the
whether
disease. Yes.
intercostal muscles are involved or any neighboring structures of the intercostal muscles, or diaphragm is involved, or any neighboring structures of the diaphragm are involved.
Yes.
Okay, right.
Yes. On palpation, trachea is confirmed to be central. Apical impulse was in the left fifth intercostal space, half inch medial to mid clavicular line. Chest expansion was 5 centimeter. Vocal frame test normal. There is no intercostal tenderness. Then percussion, direct percussion over clavicle normal bilaterally. Percussion over the left and right hemithorax is normal resonant. On auscultation, normal bilateral vesicular breath sound had no normal vocal resonance bilaterally and no adventitious sounds. So coming to GI system, mouth and oral cavity normal, On inspection, shape of abdominal cavity is normal, that is capoid shape. Umbilicus central and inverted, no engorged vein, no visible peristalsis. On palpation, liver is not enlarged, spleen is not palpable.
Why
On
is this
percussion,
statement important? Liver not enlarged, spleen not enlarged, palpable. Do you think this is important?
related
It
to
is
this condition, sir.
important. Yeah, it is important because you're talking about a muscle disease case. Okay, so they can have glycogen storage diseases.
Yes, sir.
So then
Glycogen storage can
they
help
can have
organomegaly.
organomegaly. So very
Organomegaly,
important.
yes.
So you have
Yes.
rightly looked for liver enlargement or splenic enlargement, and they are not enlarged. Okay.
Enlarged, yes, sir. And in percussion, abdomen is tympanitic, no shifting dullness. On auscultation, bowel sounds 3 to 4 minutes, and digital rectal examination was normal. And so examination of musculoskeletal system, gait was waggling gait, working with support, and arms were normal, no tenderness, no pain during the restriction of movement also, and legs were normal, spine were also normal. And so
Okay.
summary. Coming to summary, sorry, sir, just a second. Huh. A 22-year-old Hindu female presented with insidious onset, gradually progressive, symmetrical, proximal more than distal weakness of bilateral upper limb and lower limb with truncal and neck muscle weakness and pharyngeal involvement, and later wasting of muscles of hand with intermittent fever.
Wasting, if it is seen more than weakness, what do you think?
Sir,
You have
disproportionate,
weakness and then later wasting. Yeah.
yes, sir. Disproportionate weakness that also more towards myopathy, sir. In neuropathy, there will be proportionate weakness.
Yeah. Mm. No, no.
In
Wasting,
myopathy, there will be
wasting,
disproportionate.
you should always think of, if there's severe wasting, you should always think of ALS, amyotrophic
ALS,
lateral
yes, sir. Neuropathy is more, yes,
motor
sir.
neuron disease,
Not only
especially
only.
the intraocular. You should
Yes,
always
sir.
look at
Following up, there will be, yes, sir.
that
Interesting.
is the first and earliest sign you should pick it up.
ALS
Okay.
and ALS. So there was a progressive, gradually progressive symmetrical proximal more than distal weakness of bilateral upper limb and lower limb with truncal and neck muscle weakness and pharyngeal involvement, and later wasting of muscles with intermittent fever, myalgia and arthralgia without any sensory involvement or bowel involvement over 5 months.
Yeah.
And on nervous system examination, there is pure motor type of quadriparesis, proximal more than distal, suggested by decreased ball, decreased tone, decreased power, 2 by 5 proximally and 3 by 5 distally, and in bilateral upper and lower limb, and diminished reflexes, along with esophageal, truncal, and neck muscle weakness.
Good. So what's your final diagnosis?
Then, sir, structures involve muscles of upper limb and lower limb, age function plus there is difficulty in shoulder abduction, hip extension, flexion, and plantar flexion difficulty, and holding objects family, neck muscle weakness, age evidenced by neck extension and flexion weakness, and truncal muscles also involved, like she had difficulty in getting up from lying position, and esophageal muscles, she had history of dysphagia.
Good.
Then, sir, provisional diagnosis. So, neurological, it is a element motor quadriparesis along with neck and truncal muscle weakness. Anatomical locations are located to muscle. Pathologies are inflammatory, as evidenced by history of arthralgia, fever, and myalgia. And
Why do you say
etiology may
muscle?
be
Why do you say muscle?
myopathy, not neurons are we ruled out
It is proximal more than distal.
proximal more than distal.
There is no sensory component. There
No
is no
sensory component.
bowel involvement.
Yes, sir.
Reflexes will be present, but at the later point of time, they'll be
Later they
absent.
will
Okay.
absent. Yes, sir.
Why do you say inflammatory?
So, due
Because
to
there
presence of
is fever,
intermittent fever, arthralgia, myalgia,
arthralgia, myalgia,
myalgia.
slowly progressive, subacute in onset.
Yes, sir.
Etiology may be autoimmune, may be viral, maybe
Maybe
due to cancer. Okay, good. So,
cancer,
so
yes, sir.
you say it as idiopathic. Good.
Idiopathic. So it may be idiopathic, inflammatory myopathic, very polymyositis. So
Okay.
coming to differential diagnosis, dermatomyositis, limb girdle muscle dystrophy, motor neuron disease, myasthenia gravis limb girdle type, and mitochondrial myopathy.
How have you
Means-
ruled out all these
Yes, sir.
conditions?
This is table, sir. Then
Yeah.
dermatomyositis points in favor, sir, proximal symmetric weakness and myalgia. But points against, sir, only there is no skin manifestation. The signs, typical signs of dermatomyositis, heliotropras, salt sign, salt and pepper rash, V sign, no Gottron papular Gottron sign.
Yeah.
Then, sir, limb girdle muscle dystrophy. That also point in favor was proximal muscle weakness, but point against was limb girdle only involves proximal, but here there is also later on distal weakness, and in age of this patient was third decade, 22 week, but generally LGM limb girdle muscle dystrophy is seen in first decade, sir. Then, sir, motor neuron disease, points in favor, sir, weakness and atrophy, and point against, sir, weakness is more than atrophy, disproportionate weakness that is generally seen in myopathy, and there is no fasciculation.
Okay.
Then, sir, myasthenia gravis, limb girdle type, points in favor, weakness of proximal upper limb and lower limb, and points against there is no fatigability, no diurnal variation, and no extraocular involvement also. Then, sir, mitochondrial myopathy, points in
Why
favor, sir.
in myasthenia gravis, ocular muscles are more commonly involved?
Sir, maybe there due to that type 2 fibers, there's a, I don't know.
No, no. The moment you said type 2 fibers, I'm reminded of anything. Why can't it be steroid myopathy? They might have started on steroids, no? Treatment, they
Yes,
might
sir.
have started on steroid. Why can't it be steroid myopathy? You said
No, sir,
treatment, they get
that
swollen also.
initially she started weakness, then after she developed, given some treatment, which treatment we didn't know. But
Steroid
if
myopathy, there will be definite history of usage of steroids.
definite history
History.
of use, yes, sir.
Okay. Second thing, they'll have clinical features of steroid use, like
Causing or
Cushing or
faces, causing or faces, yes, sir.
yeah, moon phase.
Moon faces,
And
yes, sir.
third thing, I don't know about your investigation, but if you do EMG, EMG will be normal in
Normal,
steroid
yes, sir.
myopathy. Why? Because steroid myopathy affects type 2 fibers,
Type
whereas
2,
EMG picks up only the type 1
type
fibers.
1, okay, sir.
Steroid myopathy, EMG will be normal. So if you have doubt whether it's a relapse or whether steroid-induced myopathy, you can always check out on EMG. In
EMG, yes, sir.
myasthenia gravis, why the ocular or the eyelids are preferentially involved? Ocular myasthenia. In fact, most of the myasthenia starts off with ocular involvement. Why? One, we keep on using. There is no rest. You keep on
No
seeing
rest,
there,
yes, sir.
looking.
No
There's a
rest, yes, sir.
continuous activity going on. So
Yes,
it
sir.
is easy fatigability. So post-synaptic disorder, easily they get affected. There is ptosis. Second thing, the motor units. If you see the number of fiber per motor
Very,
unit, easily it can get affected.
very.
Because of
Okay,
these two reasons, ocular myasthenia is more common. Myasthenia affects ocular muscles more commonly than other muscles. Then it starts affecting other muscles.
okay, sir. Continuous involvement, and one is, sir, motor unit,
Yeah,
large number of motor unit,
number of fibers.
number of fibers, okay, sir. Then, sir, mitochondrial myopathy, points in favor, sir, female patient, and this weakness was also due to myopathy, and points against no family history or maternal history, and no extraocular involvement also present.
What is
And
this
sir,
maternal history?
sir, mitochondrial gene generally transferred from mother to daughter only, sir.
Yeah, it is a maternal inheritance. All mitochondria, it comes from the usual, most of the time, not necessarily all the time, most of the time. They should ask about maternal history. Good.
Maternal,
Mitochondrial disorders mostly through mother, right? Whose
yes.
side? Okay.
And sir, investigation. On CBC, hemoglobin was 11.2, total leukocyte count was 8,010, neutrophil 59%, lymphocyte 31%, eosinophil 2%, monocyte 8%. Platelet was normal. There was signs of inflammation age evidenced by ESR raised 50 in first hour, and CRP quantity was also raised, that was 20 milligram per deciliter. And urine routine microscopy was normal, sir.
Okay.
Then, sir, LFT and RFT, liver function test, we found enzymes that are related to muscle like AST and ALT were raised. 165 international unit per liter of AST, and ALT was 124 international unit per liter. And, sir, the LDH also raised, that was
See,
2020
gamma
milligram per
glutamyl transfer is very specific for liver disease.
liver, sir.
GG.
That will be not raised here, yes, sir.
CPK is very specific for muscle disease. That's
Muscle
how you can
disease,
differentiate. Okay,
yes, sir.
right.
Then serum, then we do DCT acid, that was negative. Thyroid also we ruled out, TSS was normal. ANA profile was negative, and serum creatinine kinase, that is specific for muscle, that was very high, that was 4086. And so this is the investigation reports. First one is ENA profile, that was absolutely negative. And CPK was 4086. Then these are the EMG reports, sir, which showing short amplitude, short duration, motor unit action potential, sir.
Again, it shows that the type 1 fibers are affected.
Type 1 fiber. So
Stereomyopathy
this was
affects
the
stereotypes. So
reports.
there is abnormality on EMG.
Yes, sir.
Okay, so it's
This
a
is the
myopathy.
report of.
Yeah.
Yes, sir. This is the report of NCS and EMG. In NCS, there was decreased motor action potential in bilateral median nerve, and in EMG, there is short duration, low amplitude, polyphagic motor unit action potential with complete recruitment seen in right deltoid and right vastus medialis, which is suggestive of myopathic pattern.
What about fasciculations? They're not mentioned.
Sir,
Fasciculation, no fasciculations.
no fascicles, sir.
Again, in favor of,
Myopathy,
oh, yeah, myopathy. Not
muscle
in
less,
favor of MND. Yeah.
MND, yes, sir. No fascicles. And sir, this was the MRI of the muscles, sir. There is a steer section, sir, that is a short inverse T1 recovery. So they in that sequence we generally suppress the fat and we see the muscle fibers, and there is a diffuse hyperintense in almost all the muscles surrounding the femur, sir.
Yeah.
So MRI report diffuse increased steer signal noted in bilateral thigh muscles without any focal lesion or collection, suggestive of myositis.
Okay.
And so final diagnosis, this is a subacute pure motor element quadriparesis involving truncal, neck, and esophageal muscles without any skin lesion and without any bladder valve involvement also, suggestive of idiopathic inflammatory myopathy, query polymyositis. So we have sent the biopsy and the biopsy report is awaited, sir.
Have you started treatment with steroids?
Yes, sir, we have started, sir.
How is it improving? Is patient
Sir,
improving?
initially she was not working, but now she is working with support, sir.
That means there is improvement.
Improvement.
A person with suspected myopathy improving with steroids always suspect inflammatory myopathy.
Inflammatory myopathy.
Fantastic response to steroids because it's an inflammatory disorder. So here favors in points in favor of polymyositis, I feel is one, a subacute onset, predominantly proximal muscles being involved, high level of CPK elevation. You see this in Duchenne's muscular dystrophies and you see these in inflammatory myopathy. So high,
Inflammatory
you can
myopathy.
see
Very high, sir.
4,000 CPK level.
50 times is
And third, a very good response to steroids. Always think of an inflammatory myopathy. Fantastic response. Patient is improving. So all these things again are in favor of an inflammatory myopathy, polymyositis. Good. Your final report. Good. Nice presentation. Yeah.
Thank you, sir.
Thank you. Yeah, thank you. Yeah, this I've done, but as Kishan sir was telling, I have my own YouTube channel, Dr. Srinivas Medical Concepts.
Yes, sir. Yes, sir. I
One
have
of
seen, sir,
the
you have
most
your
popular
own
neurology
channel.
educational YouTube
Yes,
channels
sir.
of India. I
Sir,
have more than 21,800 subscribers. I have uploaded nearly 390 videos. Almost all the contents of neurology are there. So
yes, sir.
please see it, like it, and share the link. Okay.
Sir,
Nice presentation, Agasti.
thank you, sir.
Nice. Yeah, over to Dr. Kishan Rao, sir.